afternoon. I thank you. Hope you all enjoyed lunch. My name is John Timmins and I'm the Clinical and Education Manager for Smith & Nephew. We've sponsored this workstream session, excuse me, a bit loud, this afternoon because this session was all about innovation and improving outcomes through innovation and change. And one of the things that Smith & Nephew as a healthcare company has been trying to do over the years is to try and innovate through wound care technology. And our first two speakers this afternoon will be talking to you, one as a clinician and one as a patient, about their own personal experiences and how a new negative pressure, portable negative pressure device has helped them, one obviously as a clinician to improve their service, but also to show you how it's impacted on a patient. Our first speaker this afternoon is Shan Fumarola. She's a tissue viability nurse from University Hospitals of North Staffordshire. Shan has been working there for a number of years and has grown into her role. I've talked to her today and she covers paediatrics. She covers more surgery than she's ever done before. And as I say, she's in charge of a large area. I don't know how she gets around it all in terms of specialties and things, but as I say, completely dedicated to her job. And innovations like Pico, like other products that come around which change our job, make our job better and easier, and make life better for patients have a huge impact. And she's going to talk to you today about how innovation in wound care can help the patient and the organisational agenda. Shan.
Thank you. Thank you to Smith & Nephew for inviting me along today to share some of my experiences with you. I'm the tissue viability specialist nurse, leading a team of specialist nurses at the University Hospital in North Staffordshire. It's a specialist centre, the West Midlands area, with a number of specialist services that we provide. We're also a major trauma centre, treating more than 100,000 patients a year in our emergency care centre. We treat over 600,000 patients per year in the hospital. 41% of those are elective admissions and 59% are emergency admissions. We've got 1,300 beds, over 7,000 staff, and we're about to move into, well, we've already started to move into this week, our new PFI. The hospital has a £416 million income per annum, so it's quite a big NHS institution with lots of challenges, as you can imagine. Our strategic priorities for this year, priority 1 being delivering safe care, appropriate and effective care, obviously, and priority 2, efficiency driven by innovation, teaching, research and education. And these are the two things really that I think I'm going to focus on today. Very challenging wound care. We do an audit twice a year of all our hospital patients, and we found that these figures are pretty static across the quarters really. 30% thereabouts of our patients attending one time have a wound, and that wound can be, various different types of wounds, but predominantly, as you'd expect for acute services, predominantly our patients have surgical wounds. Also, we have a lot of pressure ulcers, leg ulcers, burns, skin tears, and lots of other anomalies. So you can see there's a huge focus and a big cost here in terms of managing wounds. Wounds. Going forward. We all know, don't we, what the demographics are going to look like. I don't need to tell you what the demographics are going to look like over the next 50 years. And these three demographics here, age, obesity and diabetes, really impact on wound management. And along with these things come chronic conditions. And we know that most people over the age of 70 have some sort of chronic wound condition. And most people over the age of 70 often have a chronic long-term condition as well. And the two very often go together. So we're looking at vast amounts of people here going forward who are going to have compromised skin, compromised tissue viability. And should they have a wound or a lesion in their skin, it's going to be very difficult for that wound to heal. And of course, there's going to be a lot of quality issues, a lot of cost issues associated with that going forward. Very interesting slide, I think, here. I was quite startled to see that in 2050, how many people will reach their 100th birthday. And what does that mean for us in terms of healthcare provision for those patients in managing their skin and managing their wounds? Difficult to heal surgical wounds here. In 2001, NICE estimated that 21,000 patients per year would experience surgical wounds that were difficult to heal. I can tell you that's actually a gross underestimate. We don't really know. We don't know what the statistics are because we don't measure them. We don't measure how many patients have wounds that don't heal. Some of those are reportable in terms of surgical site infections and so on, but generally we've no idea. Some work done by Tanner recently, just a couple of years ago, from Leicester University Hospital suggested that in their colorectal patients, when they did a 30-day follow-up post-discharge, they found that over 65% of those patients had very slow healing wounds. And not all of them were associated with surgical site infections, as we would imagine. So you can see here the increase in radical surgery and complex surgery, hospital-acquired infections, and early discharges. It's very difficult to keep track of the real numbers here, but I can tell you they are very, very high. One of the biggest sort of drivers for us really is sort of maximising capacity and planning effectively and working differently. You know, and this is where we see our collaboration with industry, some of our industry partners in terms of wound management. We've got very, very little spare capacity within our PFI. I think the spare capacity is going to be something like 46 beds. You know, that's a really small number to work with, isn't it, when we have a lot of increased length of stay through wound breakdown and difficult to manage chronic wounds. And so we all need to work very collaboratively here to keep these numbers under control. Wound infection. When we did our wound audit in October of this year, we found that there were 25 patients with clinically infected wounds, and that might seem like quite a small number, but if we imagine that those 25 wounds increased length of stay by 5 days only, at a sort of a nominal £250 a night, and we can argue about that figure. You know, we might think, well, the cost isn't very much, but when we look at the bed capacity issues there, that can be quite high. When we look at the economics and expand that across the trust of managing patients with complex wounds, in the first 3 quarters of this year, we saw 750 patients with complex wounds. Most of those patients will have a far greater length of stay, extra length of stay than 5 extra bed days. But if we just look at those 5 extra bed days for those 750 patients, well, the costs are increasing quite staggeringly. But the bed days, which is where we really have issues here, and we're going to have lots of issues going forward, are quite shocking, really. A large part of our focus as a tissue viability team is around surgical wound management and management of incisions. There's a very high cost associated with dehiscence of surgical wounds. If we look at all the wounds that we were asked to see over Q1 of 2011, 29% of those were abdominal wound dehiscence. Now you can see here from the statistics, you know, the mortality of 15 to 20% of those wounds, you know, the increased cost here, not just to us, but to the patient as well in terms of that increased length of bedtime, that loss of income, the pain, you know, and all the discomfort surrounding a dehisced wound is quite difficult. And I know you know, our next presenter will be able to expand on that for you. For a long time now, we've been using topical negative pressure as our treatment of choice for patients with dehisced abdominal wounds and other dehisced wounds as well, but just to focus on the abdomen here for a moment. And we've used this very, very effectively, and we've been able to reduce our length of bed stay for these patients by about 2 weeks on average. But for a long time, we've had big problems in moving these patients out into community services. You know, there's been a risk associated with sending a patient out with a medical device. There's also been some cost issues with commissioners, and I know it's been a bit of a postcode lottery, really, you know, according to kind of where you live geographically. I mean, I've had really big problems sending my patients out to local PCTs, whereas I could discharge a patient nationally with a negative pressure unit. So, you know, there's a lot of disparity here. But nonetheless, we've been using this system, and we've been using it very well, and we've found ways around this. And you can see here we've got a patient with a dehisced abdominal wound, very painful, very wet, requiring a daily dressing. We've been able to implement the negative pressure unit, and we only have to change the patient's wound twice a week, which is obviously very, very cost effective and much better for the patient. We can get the patients up, we can get them mobile very, very, very quickly, we can get them out of high dependency areas, we get out to the ward, we can mobilise them, we can transit the patient home, because what we find is where we've got a very big, very complex wound, if we can manage that wound and bring it under control, everything else seems to fall in line, and we can move the patient through the system very, very quickly. What we've done here is we've moved the patient onto the PICO unit, which is a much simpler unit to use. It's just, for all intents and purposes, really, to the layman, it's just a dressing. It's a dressing that we would apply in the same way as we apply any other dressing. We now have a very small unit rather than a big bulky unit with a canister that the patient has to carry around with them. There's no added on rental cost here for the equipment. In terms of risk, the patient going home, the risks are reduced significantly. The dressings can be prescribed on FP10, so there's no rental. The cost is significantly less using this unit. And we thought, you know, this is very simple. Is this going to work? We used the system in some of our very, very complicated cases, and we found, yes, it worked equally as well in many cases as the traditional negative pressure system did. This particular patient has undergone 2 laparotomies, ended up with an open, well, we would call this a superficial abdominal dehiscence because we've no major organs here. But we were able to use this dressing with a filler material, and we actually applied this dressing and sent the patient home on the same day, and the patient was seen twice a week by the district nurse and went on to heal as we would expect the patient to heal with a conventional negative pressure dressing, significantly less cost, and obviously the patient left our facility 13 days earlier than we would have expected him to. This is probably a bit of a more complicated case of a patient with an open abdomen who is managed with conventional negative pressure dressings for about 4 weeks. I think we managed him with conventional negative pressure wound dressings. We moved him on to the PICO system. He was able to get up and mobilise with the system. He found it quite difficult mobilising with the traditional negative pressure system, but he was able to get up and mobilise with this system, and he was able to go home intermittently prior to his skin graft. We prepped him for a split skin graft using the system. And, you know, we were able to manage the split skin graft. We actually splinted the split skin graft, post-graft, for 5 days with the PICO system also, and he healed really well and was able to go home. The thing that I think that is emerging as being quite an interesting concept really here with the PICO is incision management. Now, we know many of our patients who suffer surgical wound breakdown and dehiscence, we know that there are risk factors associated with this, and we know that if we can predict the patients who are going to dehisce post-operatively, we can support that incision line, and in some cases we can actually prevent that from happening, and we're starting to see this now. So this patient this is an inner thigh wound from a vascular graft, and we were able to support this suture line while the patient's leg was very, very edematous. The wound didn't dehiss. We actually left the clips in there for 5 days, and we used the PICO system over the wound, and we were able to prevent that wound from dehissing, and I'm fairly sure, because this wound had already started to come apart, I'm quite sure that that wound would have dehissed had we have left it for another day. But as it was, we were able to support the suture line, and the patient actually went home with this dressing in situ. So you can see from, certainly, you know, from our capacity, you know, sort of standpoint, although we still have some work to do in terms of our length of stay in elective and emergency surgery, I'm sure that the way that we're working with industry, you know, to find different ways of using this technology is certainly helping our productivity here. Thank you.
Do we have any questions for Shannon at the moment? Okay, I think we'll move on. I'll just introduce Tony. Thank you, Sean. I just want to introduce our next speaker, who's Tony Grange, who has travelled all the way up from St Albans today, from Harpenden, and he's a patient who has recent experience of surgery and then a negative pressure dressing. I'm going to stay up here and change and put the slides on. I asked Tony to tell me a little bit about himself, and he said he's 65 years old and he works as a security advisor for a small family-run retail company, Marks and Spencer's. So I'll hand over to Tony, who'll share his experiences with us.
Good afternoon, ladies and gentlemen. 65 years old. I live in a small but perfectly formed town called Harpenden, which nestles between St Albans and Luton, which is a bit like living between the devil and the deep blue sea, if you will. I work, as my friend indicated, at Marks and Spencer's as a security advisor, So should I not be here, I'd be out there chasing or keeping bad guys and girls on their toes with my team. Enough about me, really. I cut back to the early part of this year. In this early summer, I was diagnosed with some quite serious heart problems. Where I was admitted to Lister Hospital, which is in Stevenage, and they undertook a couple of non-invasive operations there, namely stents, which didn't really do the job. And so I was then referred to the Hammersmith Hospital, where they diagnosed a faulty artery and a requirement for a valve replacement. This went ahead very successfully, I'm happy to say. That's why I'm sitting here. The only downside was that the donor graft had to come from my inner thigh, a particularly warm place and not very good to heal. And from the onset, it was very evident that this was going to be tricky, to say the least. It was going to present us with problems. The whole issue went on for about 3 weeks, which involved 3 more procedures, 2 debridements, and some heavy sutures being fitted in the last instance. And really, there was no good sign of improvement. It was really a long-term job. Well, as you could see, I live in Harpenden and I was in London. My family couldn't come and see me, so I pressured the hospital to say, please let me go home, let me go back to Lister where my family can see me. Well, within hospital budgets, eventually that happened. I got back to Lister and was introduced to a tissue viability nurse, Supergirl called Heidi. I could see by the expression on her face when she first saw the wound, oh, this is another one, you know, and she dressed it. But the following day we were back to square one again, and so we sat down together and she indicated to me that she had seen this new product from Smith & Nephew called Pico, and would I be willing to try it? Well, by this stage I was willing to try anything short of amputation. And the following day she presented this pack. She'd never seen it before, apart from a demonstration, never used it before. But within 10 to 15 minutes we had the thing in place and it was working. And from that time it was a lot more comfortable. She checked up on me for the next 7 days. We didn't touch the wound and it was fine. And the pain levels were certainly a lot less. I wouldn't say they'd gone away altogether, but they were certainly a lot less. On the 7th day, she took the dressing off and there was a marked improvement. I'd say 60 to 70%. The wound was really starting to heal. One of the things that came to mind as a layman, the pluses were the lack of training that was required, because this was the first time that Heidi had seen it. She read the instructions and put the thing on, and it worked out of the box. And I know that's a bit of a cliche. From a patient point of view, I found the whole thing a bit more comfortable. It was portable. I wasn't carrying a big bottle or a kit round with me, but the real big plus was I could take care of my own personal hygiene. I go in the shower, take the pump off, shower to my heart's content. It was waterproof, came back, reinstated the pump, job done. And that was the big plus for me, a real big plus, because I don't care who you are, we've all got our personal pride, and although bed baths might look attractive, they certainly are not. Just 1 week later, I was discharged back home into the care of the district nurse, who took one look and thought, oh, what's this we've got here, you know. But I said, well, this is what we're going to use. And he had no training at all whatsoever. He literally read it out of the box. Once again, had it on between 10 and 15 minutes. Paid me regular visits on every couple of days, but nothing was to be done. At the end of that session, he took the dressing off, and there was just a very small amount of seepage, and so he called belt and braces, put another one on, and left it for another week. At the end of that week, I was up, ambulant, and the wound was completely cut and dried. Thank you, ladies and gentlemen, for your time and listening. That was my experience with Pico.
Do we have any questions for Tony? Yes.
Story, Tony, how long did you have the wound before Heidi got to you? Like
Between 3 and 4 weeks.
4 weeks.
Yeah.
And how long did it take to make?
Just over 2 weeks.
Jackie.
Did you think you would have been able to change the dressing yourself? You said it was very simple.
Yes, yes. I think the crux of, if you can read, you can do it. You know, because they weren't specialists in this field, and I presume they could do ordinary bandages, but compared to an ordinary bandage, it was simplicity itself. If you can put a plaster on, you can use Pico.
Yes, sorry.
That's a very simple question. Why weren't you offered it first up? Why did you have to go 3 or 4 weeks?
My surgeon at Hammersmith had a real brick wall against vacuum management. He didn't like it, wouldn't use it. It was a complete change of thought when I was moved to the Lister. But I went back to the Hammersmith for a referral, just for a checkup, and I met the surgeon's assistant who sat in on my operation, and I still had the Pico in situ then, and he was most impressed. He called the surgeon in, and the surgeon did a complete about turn and sang its praises, and was very, very impressed, and was going to go along to his people and talk to them about it.
Any other questions? Thanks again, Tony. That's fantastic. Thank you. Our next speaker for this afternoon is Jackie Fletcher, who is a senior professional tutor from Cardiff University School of Medicine, and she's also a NICE fellow, which we discussed outside. They might need to change that, but she is a very nice fellow. I've known her for a long time. And Jackie's going to talk to you today about pressure ulcers as a quality indicator. Thank you.
Thank you, John. Oh, my presentation's not joined on. Right. There we go. It does cause some problems being called a nice fellow. You can see people giving you strange looks every time you say it. There we go. So what I want to talk to you about today, a little bit of this Sian's already mentioned, but I think certainly considering the current government priorities and the current quality agenda, wound care generally lends itself very well to that agenda. And one of the things that we are very conscious of in our field is that there are many areas where care could be improved. Because if you look at how wound care is provided across the UK, what you will see is that there are no approved standards or pathways of care, although we are conscious that with the AQP programme currently underway, we are looking at providing a pack for leg ulcers and some for wound care. But depending on where you are treated, as very ably illustrated by Tony, will depend very much on the care that you have given to you. And some of that may be on personal preference, and some of it may be very, very evidence-based. Some of it may be less so, as some examples I've seen recently in practice. And an example of that might be, we've been working with our midwives, and I've not got the pictures, you'll be pleased to hear, I've not got the pictures, looking at some of the perineal breakdown in ladies following delivery. And although our midwives, our consultant midwife led, their delivery care is fabulous, once these women leave their care, and we are seeing quite a large number of them who are experiencing this breakdown, the advice they're being given is to put a sanitary towel in the freezer, then put it in a freezer bag and use that, and in between time to pat their perineum with witch hazel. Now, I can see all the ladies cringe immediately. That's just an example of how not all wound care is evidence-based and how the standard varies. So we know that care is provided in a variety of ways. The cost of wounds to the NHS is huge, and Sian very ably illustrated the amount of some of the complex surgical wounds. We know that they delay discharge. That's not complications of wounds, that's developing a wound. And they can cause preventable admission, and they can cause a lot of preventable readmission. So we see many patients having to be readmitted because of wound-related problems. They have considerable morbidity and mortality, and they have a major impact on the patient experience and on their quality of life. So this can be the thing that colours the patient's experience of their NHS. We know that in a typical acute hospital, between 25 and 40% of beds are occupied by patients with a wound, and as Sian said, a lot of those are surgical wounds, so these are planned wounds, we know we're expecting them, but a lot of them are also unplanned events. But the majority of these patients receive their wound care in the community, and it accounts for sometimes 60 or 70% of a community nurse's time. And also we know this will get worse. Sian showed you the demographics and how they're changing, so we know that this will continue to increase. What I want to focus on is pressure ulcers, and the reason I'm focusing on pressure ulcers is I'm sure you're all very aware, wherever in the NHS you work, these are currently high on the NHS agenda. We're using their occurrence as an indicator of the quality of care provided, and therefore we need to be ensuring that what we're doing is appropriate, evidence-based, timely, and is the best that we can achieve. They've become very, very high profile. As John hinted, I've been in wound care for quite a long time now, and certainly this has been one of the things that I have been struggling to raise the profile of for a long time. I trained in the 1980s in a London hospital, where I was very fortunate at that time. My director of nursing, who was a lady called Pamela Hibbs, was very interested in pressure ulcers. And when I moved to work in Manchester, I was astonished that the same level of support was not there. I couldn't just phone up and get a mattress. I couldn't just get dressings. And that's still the same situation we're seeing in some places. But luckily, over the last few years, the priority of pressure ulcers has risen, and we can only see that as a positive thing. If you're not sure what we're talking about, just to give you an idea of the scope of pressure ulcers. They can be anything from this very small wound you can see here, which actually is a necrotic area on somebody's spine, and when you lift that necrotic area, you can actually see the spinal processes, to that really nasty looking large one up on your left. But the point being, they vary in size, they vary whereabouts in the body they are, but they also affect every patient population, from neonates through to those centenarians that Sian mentioned. They occur in acute, in primary care, mental health, learning disability, midwifery, you name it, those patients develop pressure ulcers. And you can see from just looking at them why they can cause problems, both for the healthcare system and for the patient. We know that approximately 20% of patients within hospital care develop pressure ulcers, and that a lot of these are hospital acquired and of the deeper stages, so categories 3 and 4, which means they are fully through the skin and sometimes through the muscle and down to bone. This really was the starting point for the work that I'm going to present to you. The major vision for the NHS for Good to Great was to set out an ambition to eliminate all avoidable pressure ulcers in NHS provided care. And we would really support that vision, and that's really important to us, but it's the wording of that that really set us a target, because it's about avoidable pressure ulcers. When we started to look at this, what's very apparent is that pressure ulcer occurrence data is collected in most clinical areas. I'm sure most of you would say, if you have a tissue viability nurse, you have some idea of what your prevalence and maybe even your incidence of pressure ulcers are. We sometimes use them to compare one area to another. We sometimes use them to compare ourselves against ourselves. But what we do know is that the way we compare them is fraught with complication. And this has been going on for many, many years, and nobody's been able to resolve it. And it's only now, when we're starting to see this as a quality indicator, that we're starting to think, actually, we're going to have to deal with some of these issues and start to talk a common language. So when we start to think about how this relates to commissioning and pathways, to me it goes back to what Darcy stated and these 7 steps that he listed, that we've got to have high quality care, but in order to achieve that, we've got to have clarity, we've got to measure our quality, we've got to publish that quality, raise the performance, recognise standards, raise standards, and safeguard the quality and stay ahead. And I'm sure that's a series of statements you all can almost recite off by heart. And what I would say is we use pressure ulcers at the moment like this. We measure them, we count them all the time, we count them. And we publish them. If you pick up any wound care journal, some of the nursing management journals, a whole range of journals, you will see papers talking about the numbers of pressure ulcers and an aim to raise the quality. However, you'll notice I haven't circled the whole 4, because the whole 7. The other 4, I believe, are missing. There is no clarity about what we are measuring. There is no standard in what we're measuring. Therefore, we can't raise the standards and we can't safeguard that quality, because we're all measuring completely different things in completely different ways. So I want to talk about 2 projects that I'm being involved in, one as a member of NICE and the other in my local region, which happens to include Lister, which is my local hospital, so I know Heidi very well. She's a good friend and colleague of mine. So the first project I will look at will be some work with Midlands and East NHS, and that's the Pressure Ulcer Reduction and Prevention Programme. The second one is on behalf of the Tissue Viability Society, and that's a two-part project looking at some data collection and a consensus conference, which if you have got a member of staff that's appropriate to go to, and that's not necessarily a tissue viability nurse, it may be your local commissioner, it may be a director of nursing, I would put a plea out, please make sure somebody attends this conference on the 21st of November. So I know that's a very busy slide and you can't see it. It's just to illustrate to you, this is how we're going to present the work. So this is being presented next week at a wound care conference. The Pressure Ulcer Management and Reduction Programme for East of England is not dissimilar to work that's going on elsewhere in the UK. I would be wrong to say this is the only project in the UK that's working in this way. But what we are trying to do, and what we have done, is across the East of England, because this was a project initiated in East of England before the merging of the SHAs, is achieve consensus. And to me, that's a major innovation, because to get people to agree is very, very difficult. And in getting people to agree, what we've had to acknowledge is that in each of the areas we're working, whether that's primary care or acute care, there has, over the last however many years, been a lot of work done. A lot of the tissue viability teams we're working with have written their pressure ulcer guidelines, they've implemented their grading systems, they've implemented a whole lot of processes, some of them only this year. But they have agreed that they will, within a very short time period, move to what we are now saying is a universal standard across our region. This working group met for the first time in September, and we plan on having information ready for commissioning in January. So this is a very, very fast-paced initiative. We are meeting every fortnight for 3 hours on a Tuesday afternoon. That's the Pressure Ulcer expert group, and we are reporting to our Pressure Ulcer board from Midlands and East. And you can see the kind of things we're starting to agree on. We have looked at the grading systems, and we know there are different grading systems in use. We know each of the trusts involved have got their own, but this is the one we're going to move to. We've decided that's what we're moving to. We know there is national and international guidance about what to use. We have looked at the research around what nurses can and do and how well they do it, and it's very apparent to us that the only area where there is good evidence is that nurses cannot grade pressure ulcers. They cannot tell the difference between a 1 and a 3, or a 2 and a 3, or a 3 and a 4. They can, however, vaguely tell the difference between skin and something deeper than skin. So we are working towards, can you just vaguely see the lines between these? We are going to have superficial and deep, and we don't know. Not immediately, but that will come. That's what we're going for. So that when we're reporting these as incidents, we know we're reporting similar things. We're agreeing the reporting process. When we started talking about how do you record these incidents and what happens when you've recorded it, the language that started coming back at us about whether it was a critical incident or a serious incident or a serious untoward incident or a SIRI or a SUI or whatever it may be, or whether that went to RCA or not, just in the room there were 27 of us, and I think there were 27 different versions of what happened. That's what's going to happen. That's the process, and from January, that's how East of England will report and record their pressure ulcers. Now, if anybody wants to do anything over and above that, that's fine. But as a baseline, as a minimum data set, that is what will happen. The other project is part of the TVS project. We started off this project in East of England, so this survey that I'm going to describe to you was initially done in East of England. We are now looking at a working group on pressure ulcers, which I'm involved in through my NICE role, and it's very clear that this isn't just an East of England problem. This is the same across the whole of the UK. At the minute, we're focusing on England, not Scotland, Wales or Ireland, purely on England. And we decided to roll out a survey that we'd done in East of England. And I launched this one Tuesday afternoon using Bristol Online, an electronic survey, and was astonished that by that night, I had something like 40 responses. Now, we don't actually know how many tissue viability teams there are in England. We have no real idea. We estimate about 200. And this has been live for a week, and I've had 122 responses, which I'm kind of... We've put a lot of work into doing this. We've gone through the regional groups. We've made sure that people know this is a priority. But basically what we're seeing, and it's almost irrelevant that you can't read what's there, is you can see in each of these categories. So the first one is which grading system do you use? And then down the bottom, it's about would you like a simpler system and how often do you measure prevalence? The important thing is you can see everybody's doing different things. and that in each of those questions there are several different categories that they could reply to. So they're also asked about this next page is about how do you record these. So do you record this as a serious incident? Which category of pressure ulcer do you record as a serious incident? Now the NICE guidance says that anything above 2 or above should be a critical incident. So old style language. We know that most acute trusts have said if we take all the 2s, that's far too many. We're purely recording 3s and 4s, so that's anything that's gone through the skin, so deeper tissue damage. But you can see in some areas they're recording 1s, so that's if somebody gets a red bottom or a red hip, they're recording those as an SI. Can you imagine the paperwork? And some others are recording some Americanized definitions of deep tissue injury. Some are saying unstageable. So if you add those in, we've now got 6 categories. So those trusts that are only reporting in 4 categories are saying 20% of our pressure ulcers are grade 4. And others are saying only 5 of ours are. Well, that's because they've got 6 categories to choose from rather than 4. So can you see that that really doesn't work? We're not getting the same information. And the bottom one, next to the bottom one on the line, that little yellow blip is moisture lesions. Moisture lesions are incontinence-associated dermatitis type problems. Things where bottoms get wet from diarrhea, incontinence, sweat, and the bottom gets a wound. Some places are calling those pressure ulcers. They're not. You could put those patients with those wounds on a pressure-relieving mattress, they will not get better. You need to get rid of the moisture. But they're counting them in their pressure ulcer data. So if you're counting them, take them out, your pressure ulcers will get much less, be much, much better. So you can see, again, huge differences. So which are you recording as series or SUIs, who are you doing RCAs on? And again, if you look at who people are doing RCAs on, some trusts are doing red bottoms as a root cause analysis. We also have some nurses describing to us that if they admit a patient with a pressure ulcer, the acute team are being required to do an RCA, although the patient came from the community, and sometimes vice versa, which is utter nonsense. How are you supposed to find that kind of information? And this is the final question that's on there, and to me this is one of the key ones, particularly for hospitalised patients. What we're looking at is when people are saying, that occurred in my care, this is my problem. So we ask them, do you have a definition that you work from of when that is your problem? And the options are, no we don't. Yes, anything the patient has when they're admitted to our care, anything within 6 hours of care, which is from the NICE guidance, and then some others, and then the larger bar down the bottom is anything noted within 72 hours, which is from the quality indicators. But again, you can see there's a huge variance in the timescale. Now, within East of England, we've got Papworth, so my colleague Fiona from Papworth says, if I didn't record anything within the first 72 hours of admission as being a pressure ulcer responsible for me, I wouldn't have any pressure ulcers. Because a lot of her cardiology patients walk in, perfectly intact skin, and within the first 72 hours, they've had a whole range of angios procedures, 16 hours in surgery, been opened from here to here, bits taken out of their legs, within the first 72 hours. And if they've got a pressure ulcer then, how can you say that that was about what happened in the community? It just isn't. So we know these are huge problems, and again, if you're attributing the blame, I'll say, I hate this, but blame, then that's not right, it's not appropriate. So we know there are big differences. So hopefully by the end of next week, we will have a picture across England of what the differences are in these definitions that are used. And I think that will be quite useful. That's going to be taken to this meeting that I mentioned, which will be in Birmingham on Monday the 21st. And the plan is that based on what we're already seeing and the work that we already know, we're putting some statements up for discussion with a hope of getting some agreement. So we're going to say, these are the 4 definitions we know of unavoidable. Which should we go for? Let's all agree. These are 3 different ways of calculating pressure ulcer incidence. Let's agree. So, small example, when we count pressure ulcers, there are 2 key definitions, one from an international document, one from the Department of Health. One tells you to count patients and multiply by 100. The other one tells you to count pressure ulcers and multiply by 1,000. Now, one patient can have 7 pressure ulcers. So depending on which you count, you're going to have a very different number. And equally multiplying by 100 or 1,000, you can have a very different number. So we're trying to find some consensus in what we do. So in terms of quality issues and for your quality agendas, you need to be aware that there are these discrepancies out there in what's happening in the data that's being presented to you and that's being collected on your behest. So in terms of where we're going with this and why this fits into this quality agenda and this prevention agenda, is we are trying very hard to standardise the terminology. We are creating what we hope are widely accepted definitions. We realise that these will take some time to come into wide implementation. Not everybody can change things overnight. We know how that works. We're starting to outline some pathways of care, which include clear, crisp care bundles. We've had long discussions about the care bundles, the pressure ulcer care bundles, and we've seen people trying to add things in. So there are two around, a Scottish one and a Welsh one, both of which are SSKIN, skin with two S's. And people are trying to do things like add pain in. And we shouldn't add pain in. Pain isn't relevant in a pressure ulcer bundle. I'm not saying patients with pressure ulcers do not get pain, they do. What I'm saying is the pain, relieving the pain won't get the pressure ulcer better, because what the pain does is make the patient either immobile or fidgety, and the problem is the mobility. So yes, manage the pain, separate issue. It's not part of the skincare bundle. We're defining interventions which make a difference. We're looking at the intentional rounding, we're looking at what's counted in that intentional rounding, what people are doing. And as I showed you with the RCA structures, we're looking at agreeing reporting structures and mechanisms. So hopefully if we can start to pull all this together, we can start to improve the quality of not only what's happening to the patient, but what we're using as data and what we're managing as data. So hopefully what this will all do at the end of the day is make a difference for our patients. Thank you.
Do I have any questions for Jackie? Yes.
I work in infection control, so not tissue biology or wound care. But I'd be reticent about stopping people doing an RCA whether you think it's yours or not, because we now do for anything that we do an RCA on, whether we think it's a hospital treatable or a community one, we do an RCA. We share that with our colleagues in the community, and quite often with the patients we see in acute care now, actually even if the patient, if this infection wasn't clearly by the definitions of the government set hospital treatable, there is usually some hospital or acute influence because that patient's usually been in the hospital in the preceding weeks or months that might have impacted on that. And actually, what we're finding is we're getting better information because we're collaborating rather than kind of sticking within, we're defining the patient and their complications and issues rather than our artificial boundaries to their care.
I wouldn't disagree, and that's one of the things we're considering, but I've been given examples of patients who've never been in hospital and have arrived in A&E with a grade 4 pressure ulcer. We've never seen them before, yet the hospital staff are being expected to investigate that. To me, that's utter nonsense. They've got no knowledge of what's happened in the community. Now, what we find sometimes is that patient's not seen a healthcare professional at all. So, and that's part of our definition of unavoidable. So, yes, we wouldn't say we don't want to do any of those RCAs. What we're saying is there has to be some common sense in how they're done. And if you start proceeding into the RCA and it's very clear that this is a community issue, or if your community and it's a hospital issue, that there is communication between those two. Because it's not about attributing blame, it's about looking at what went wrong. And I think that's what we're seeing as a problem. A lot of people are seeing this as, it's yours, not mine. Whereas, in fact, it's the patient who's got the pressure ulcer, and what we want to do is stop that happening.
But isn't that about defining the process? Because
that's what we're trying to do.
Unless you go back and look to say this patient hasn't been here, or it may have been in another acute case, or it may have been in a community not having it. Until you actually go looking, you can't confirm that there's not a respiratory alert.
Yeah, that's what we're doing. We are doing it, but we're trying to make sure everybody's doing the same. And at the minute, there are so many different pieces of paper. Some people have got one side of A4, others have got 26 pages. So we're just trying to bring it back to something sensible.
Yes.
Am I allowed 2 questions?
Yes. Yes, go for it.
Thanks, John.
When you defined or gave your vision for the new categories of pressure ulcers, which I find eminently sensible, what would don't know be?
Sometimes there are wounds that have got a necrotic cap on. So particular heel ulcers, they've got a black hard cap on and you can't see the base of the wound. Now, if that's a bottom, generally speaking, it peels off and it's a 3 or a 4, isn't it, Sean? But sometimes on a heel, it peels off and it's just the skin. Sometimes. So that would be don't know.
So don't know would
And-
require narrative of some sort.
Yes, or it would require a review within 2 days. So it's not a end stage, I don't know. It's that I can't say now, but I'm going to come back 24, 48 hours and decide. Equally, sometimes you get a really red spot on the skin, and an experienced person would feel and use lots of other, you know, the temperature, the texture, and say, actually, I suspect that is. But you're dealing with a whole range of nurses doing this. It's not all specialist nurses. So you have to give them the freedom to say, do you know, I'm really not sure. That looks like a 1 or a 2, but there's just something else that tells me it might not be. So for today, I'm going to put it isn't.
And the second question, what's the composition of your specialist group?
Which one?
The group that you're meeting fortnightly?
East of England. There is a nurse consultant from Papworth, there is the lead tissue viability nurse for Adam Brooks and Cambridge PCT, and the lead tissue viability nurse for SEPT, South Essex Partnership Trust. There is then a whole range of management structure people, so there's a couple of dons, there is a patient safety lead, there is, who else? There's a lot of management structure in there, and it's led by a project manager from East of England.
Any medics?
We have a doctor leading the project board.
It's very interesting what you say about the blame game. In our area, secondary care blames primary care blames secondary care, we all blame the nursing homes. So, is there anything in your work that's looking at sort of nursing residential homes?
The difficulty we have, and this is a problem that's going to occur with the NICE guidelines as well. The NICE pressure ulcer guidelines are just being rewritten. The scoping document's out at the minute, so if anybody wants to read the scope, it's up. And if anybody wants to be on the guideline development group, that's up for grabs until the 30th of November. Is we are looking at NHS-funded care. So it depends on how the care is funded as to whether we can scoop them in. And our agreement is very much that because we use some Bupa beds, we use some other private organisation beds, some of our nursing homes are half and half, we are hoping that one will lead the other. We blame the ambulance personnel. It doesn't happen in our care, it's the ambulances. They do it.
Thank you very much, Jackie. That's great. Thank you. Thanks, Tony.
Hopefully what I'm going to talk to you about builds on the discussions that you've just heard. I work for I lead the infection prevention team at University Hospitals of Leicester. Judith Tanner, actually, who Sian alluded to, works for De Montfort University, so she works with us. So I'm quite familiar with Judith's work, and we do a lot of good collaborative work together. We are a large NHS trust, not that we're in the game of saying who's biggest, but we have 2,000 beds, 12,000 staff. We're spread over 3 sites, and that's a significant challenge for us, as you can well imagine. But then no bigger or lesser challenge than any of us, I think, in the NHS today. Our journey started in 2009. We received an award from the Department of Health. As a group of hospitals around the country received an award for technology innovation, or the Innovation Award. We had successfully reduced our CDT and MRSA figures, and we were very proud to receive that award. And that's Dave Jenkins. On my right is consultant microbiologist who I work very closely with, Fiona Pym, a colleague of mine, and that's, his name escapes me, but you'll know who he is. Philip Hammond, that's right.
He believes you're a lonely, depressed, alcoholic, divorced person.
That's the one. No, not me personally, no, absolutely. Very, very pleased to receive the £150,000, which was obviously a huge amount of money from our perspective. We knew immediately what we wanted to spend that money on. We always knew that we wanted to have a patient management system from an infection prevention team perspective. Prior to this, everything was pen and paper, basically. And I'm sure there are teams around the country who still use pen and paper, which is pretty archaic if you think about technology and what it's able to do for us. So we went straight back to the trust and said, £150,000, what can we spend that on? We wanted a patient management system, and we chose ICNet, and that's the system that we set about purchasing. And I say set about purchasing because the system went live this year on April the 1st. So if you think that the award was 2009, system went live this year. We had quite a journey, some of which was, well, all of it, I think, was, I say our fault. I think I'll talk about that as we go on. We also used Sequin. We realised when Sequin came about in 2008, there was an opportunity to use the Sequin quality and innovation to enable us to develop surveillance and to develop surveillance within within our hospitals. From an infection prevention perspective, surveillance really is key. We believe it's key to what we do because it's key to enabling all of us to spend our money most effectively. Resources are now so scarce that it's crucial that when we're asked to spend money, we know that we're spending it with the greatest patient effect. And I think that builds on the work that clearly colleagues in tissue viability are doing. So, as I say, we use the Sequin to help to develop our surveillance team. And we really challenged, or we feel that we've challenged the status quo, because retrospective data for us wasn't really good enough. The HPA have for many years provided a surveillance system through the NINS project, and I know Jenny Wilson, and it's been a superb programme, but we wanted to have data that was in real time. We wanted to be able to feed back to clinicians monthly infection rates and quarterly reports that were meaningful, that allowed them to look at their practice and say, what are we doing here? How can we make sense of these infections? What can we do about these infections? And what can we then do to actually affect a patient outcome? And that's why it was so nice for me to see Tony, because it's really easy for us all to get very caught up in data and systems and processes, and actually all of that has to be about the patient at the end of the day. It's all about making sure that we deliver more effective, value for money patient care. We went on to think about this in more detail. The HPA analysis is delayed in reality. It isn't real time. The analysis doesn't measure compliance data. And so when we set about designing our surveillance system within Leicester, we've actually included the collection of compliance data that relates to the World Health Organization Safe Surgery Checklist, relates to the high impact interventions, and relates to other things that we do within UHL. Within UHL, we wash all our, we don't wash, we offer all our patients an antibacterial wash. We use a product called Stelicept. So if you come to UHL and you move, you get washed in an antibacterial wash. We wanted to measure our compliance with that. We wanted to measure compliance with antibiotic nasal ointments. So we included that in our compliance data as well. So not only are we collecting the data that relates to surgical site infections, but we're also collecting a whole host of data around compliance. So that as a minimum, what we're able to feed back to our clinicians is, at a very basic level, it's the infection rate, but then with that is just how well are you doing in terms of meeting national standards and recommendations for things that actually do make a difference in terms of patients acquiring infections. So are you complying with Stelicept applications? Are you maintaining normothermia in your patients during the theatre time? What's your glycemic control? So there's a whole host of things that we measure. We really felt that we wanted to look at the process improvement drivers, performance improvement, the potential we recognised. We wanted real-time alerting, as I've said, improve our outcomes, and we wanted to alert us also to poor clinical compliance. And so we've started to do quite a big piece of work on that. The challenges that we faced, I talked about the challenges initially. I think our challenges were, some of it was my own naivety, I have to say. Some of it was the fact that we have an NHS culture where it is very difficult to get teams to talk together. We needed clearly to work very collaboratively with our IM&T colleagues and our finance teams to ensure that we could get this system installed. Looking back, my naivety was probably quite a good thing because I bumbled ahead, really, not taking too much account of the workload that they all had. But interestingly, Jim Easton mentioned something this morning that really struck a chord with me, which was about we really do need to get over ourselves. We need to understand that we have to work collaboratively. All of us have to work collaboratively. And we challenged our IM&T colleagues in a way that I don't think they'd been challenged before. We challenged our finance colleagues. And what we've ended up with is a collaborative piece of work, which I'll talk about at the end, that I hope will lead to some significant cost savings and some real benefit in terms of patient outcomes. I come originally from the private sector, and I think the NHS is very slowly developing the private sector mentality. And by that, I mean that starting to look at purchasing in terms of the purchasing buyer power of buying in bulk, being able to look at our clinical coding, making sure that we're getting all the systems right that actually make sure that we are as cost effective as we need to be. And certainly working together to look for solutions in the current economic climate has to be the way forward. And clearly working together to improve patient outcomes. So, improving quality, reducing harm, improving efficiency. We went for our automated surveillance systems. We use an automated patient management system for the infection prevention team, and we also use surgical site infection monitor package. We're working quite closely and collaboratively with ICNet to develop that even further. I think we've challenged that and what we would like out of that. And we've just been able to also go on to the antibiotic e-prescribing as well within the trust. So we're gradually getting there. Healthcare associated infection, the problem. Well, the problem, we've divided that into four. The patient, the pathogen, practice and place. And automated surveillance systems help us to find the solutions. If you think about the patient, we now have information about demographics, risk factors, procedure history, infection history, and invasive device history in a way that we would never have had those systems in the past. And probably what I should have said to you at the beginning is that the automated system brings the other systems that we have within UHL together in one place. So our patient admission and discharge system, our theatre system, our emergency department system and our laboratory system. You know, when we actually looked at it, we have all these disparate systems within the hospital. What this does, it brings all those together so that we're able to have that information in real time. We get a feed every hour from the laboratory, which allows my team to work much, well, I can't begin to tell you how efficiently my team now work compared to the way we used to work with pen and paper and having to rely on this information, often taking days to get to us. Pathogen-wise, we have a continual data stream, which is now authorised, but we can see pre-authorised results if we need to, and we can have an uncensored feed for alerts of, well, whatever organisms we want from our system. Practice, we're able to look at antibiotic usage, we can look to speciality data, consultant data, looking at conditions, and looking at protocols and able to carry out audits from that. And then, as I said to you, it's linked with PAS and links to our bed management system and allows us real-time tracking. So we've gone, I think we've been surprised ourselves actually at how we have integrated this system. I think we've been really surprised at how we have worked with our colleagues in other areas of the trust that we hadn't previously worked with, and just what benefit this has given to us. Safer care, we're carrying out a piece of work on catheter-associated UTIs. We're able to integrate the recording directly onto ICNet. It means that we are leaner in terms of our working. It's more accurate. Positive UTI alerts, we can immediately match those with the patient. We're able to undertake data analysis and reporting. We can have access now to denominator data. and alerts and measure our improvement. And in terms of general healthcare associated infection, we're able to look at identification, we're able to locate our patients, we can produce cross-infection reports, we can look at accurate admission screening, and we can be proactive in our outbreak management. These are things that I think we'd all dreamed of doing in the past, and we're now able to actually start to realise. And we're proud. We're proud of the achievement, and we're proud of the work that we've undertaken. Not least of which because it's collaborative and it's actually, as I say, bringing in other partners within the trust. We have more clarity on our problems. We have the potential to track resources to reduce harm. We have prevented some outbreaks. We had a cluster of ESBLs on one of our musculoskeletal wards. We were immediately able to send one of the team down to that ward to understand what was going on and whether they had a problem. That was something that we would never previously have been able to do had we not had access to the information technology that this system has given to us. And we, as I say, we've collaborated with teams who hadn't been part of patient-centric healthcare associated solutions before. In January 2012, we're going to be using some surgical surveillance software which will provide streamlined workflow, post-discharge surveillance and tagging of readmission surgeries. And I haven't read the guideline. The guidelines came out on the 8th of November and I was travelling here, and we've not been able to get hands on a copy of the NICE guidelines on healthcare associated infections, so they are really hot off the press. But I have no doubt that these systems will help us to move towards compliance with those guidelines if we're not already there. And going home I shall be itching to get hold of a copy of those. Placing value on our work, one of the other pieces of work that we're doing that is quite exciting. We want to try, Sean was saying it is very difficult to estimate the cost. Clearly most of your finance directors, when they're looking at how they're going to spend their money, want to know if they're going to get value for money. They want to know if they give you £150,000, what are they going to get back as a result of that? And quite rightly, as keepers of the public purse, is that good value? Should we be spending valuable resources on that money in that way? So we wanted to establish the cost for benchmarking purposes to try and understand the extent of the problem. Allocation of scarce resources. We are entering into a project with our finance team and PLIX. I don't know whether any of you know about PLIX. It's a patient level costing system. And working together with our finance team, we are going to be attempting to cost infection prevention episodes, healthcare associated infection episodes within our trust, just to see whether we can, not just to see, whether we can actually cost what we're doing. So at the bottom, this is a very initial costing from Simon Shepherd, who's one of our finance directors. A 20% reduction in health HCAIs following implementation of ICNet and IP interventions has the potential to save over £700,000 per year. A 10% reduction would be £450,000. And the next slide is, our piece of work is a collaborative approach to costing HCAIs in an acute, NHS acute trust. University Hospitals Leicester using ICNet surveillance software and PLIX to generate an approach for examining the effect of HCAIs on cost. We've known for years, all IPNs will tell you, that patients that have infections cost a lot of money. That's what Sean and the other tissue viability team have said. You could mirror in infection prevention, you could mirror in the cost of harm to patients who acquire infections in hospital. Clearly we have the same mission statement, which is to prevent avoidable healthcare associated infections. So the piece of work that we're going to be doing is looking at whether we can put a cost to this. One of the problems is your finance team will say, where is the money? It's not tangible. There isn't any tangible money. If you can change your dressing, you can demonstrate that there is a cost immediately. But it is very difficult to cost healthcare associated infection. So in the current economic climate, we do need to try and ensure that we're directing our resources in the most effective way. So at Leicester, as I say, we're undertaking 3 pieces of work. One is using the new patient management system that we have and looking at the effect that that's having on the infection prevention team in terms of their time. And I will urge here, this is about not saving staff, this is about saving staff time so they can be redirected. This is not about using an IT solution to actually reduce heads. This is about using an IT solution to actually redirect a valuable resource to where it needs to be, which is away from a computer and to the bedside, working with staff to improve care. And then we're looking at our surgical site surveillance programme and looking at the effect of measuring compliance and what that can do for us. And then we're undertaking this piece of work with our finance team in terms of measuring the cost. Those of you that may or may not know, Ploughman did this back in the 90s. And it's an old piece of work now, really, and that's the problem with it. We need it to be relevant to costing today in order for us to use that. So we're attempting to do that. And then we want to measure. We want to measure what we value. So we want to be able to look at our processes. I'm not showing you this chart because there's any particular meaning to that from our perspective other than to say that we want to be able to come up with some statistical evaluation and some statistical meaning to what we're doing that then allows us to utilise our money in the most effective way. So very happy to share our journey with anybody who might be interested. Very happy for people to come to Leicester and look at what we're doing. Very happy to be constructively criticised. It's quite new work for us. We believe there's a lot of value in it, and I think also I'd like to echo the comments of my colleagues that we do need to have some, whilst it's very nice to have individual control, there does actually need to be some strategic direction and some strategic vision, because otherwise if you've got disparate groups of people going off doing lots of disparate things, how do you ever really pull that information together, and how are you able to really utilise that across the board? So thank you very much.
We've got time for one quick question. Any questions? Yep.
With length of stay getting shorter and shorter after surgery,
Yes.
and high proportion becomes a day case, obviously a lot of the infection complications out in the community.
Yes.
I think one of your slides you mentioned about post-discharge surveillance.
Yes.
I'm wondering how confident you are you're capturing that. And also, of course, your financial argument becomes really difficult if you're proving that by using this you're saving the community costs rather than the hospital, I suppose.
Yes. Yes. Well, 2 things there. The surveillance that we undertake, we take for 30 days. So we undertake 30-day post-operative wound surveillance across all the surveillance that we undertake. No, we ring the patients. The method that we've chosen is we ring the patients and speak to them directly. We then, if the patients tell us that they've had a problem, we then speak to their GP. So we follow that up with a call to the GP, and we talk to the GP just to validate what the patient has said to us, so that we're as accurate as we can be in terms of the data that we're getting there. The other thing that I'm going to be doing, and I was quite excited this morning, and Becky and I have been writing notes all the while, I think I'm going to look at using mobile phones for our C-section surveillance, because that's a group of patients that we struggle to capture for post-discharge surveillance, because they're not in, to be fair. You know, once they've had their babies, they're young, hopefully relatively fit and out and about. So I rang one of my colleagues and said, right, we need to produce an app so that we can speak to C-section ladies, and we can offer them, we can say to them, how can we contact you post-discharge, mobile phone, app, internet, you tell us, and then we can speak to them and hopefully get some good data back, because that is a problem, and you're right. And in terms of the community, well, we'd very much like our PCT to join in and to come onto the ICNet system with us. It is available to the community, so we could actually have a whole healthcare economy usage of this system. so that we could all use the system together. And I think that would be fabulous, because the data that we could get out of that would be really quite meaningful. And then the financial teams can speak as well.
And why didn't the ICN pushing for an IC network, which will be cover the current SHA batch? So whoever the HCI for the SHA was, if they had IC network, your IC network would feed directly to them in real time.
Absolutely.
So then they've got the equal idea of the whole totality of the patch. So you're getting the kind of the numbers scale.
Yes. I mean, one of the things, you're absolutely right, one of the things I haven't talked about is benchmarking, because clearly we would like to be able to benchmark with other organisations, and that we have the same issues within IP that tissue viability have, in that people do things slightly differently all over the place. It would be really nice to be able to standardise that so that we can bring the information into one place, because then that becomes very meaningful and it becomes very powerful in terms of being able to really utilise it for expenditure.
Thank you very much, Liz. Thank you.
Thank you.
Thank you. Our final speaker this afternoon is Helen Betteridge. She's the UK Marketing Manager for Monlica Healthcare. She's in charge of therapy and new product development, and she's going to be addressing the issues around improving outcomes in pressure ulcer prevention.
Yes, I'm Helen Betteridge from Monlica Healthcare. For any of you that aren't familiar with Monlica, along with my colleagues from Smith & Nephew, we're one of the market leaders in developing and supporting advanced wound care, hence talking about pressure ulcer reduction today. Very, very quickly, I could talk about pressure ulcers, believe it or not, for days. So 15 minutes is a very short period to sort of give you a feel and an understanding of some of the passion I have for actually reducing and preventing and managing pressure ulcers. So a little bit of context about what I'm going to talk about. I wanted to share with you some new and emerging evidence that's coming through for pressure ulcer prevention, and just also talk a little bit about Monlica and partnership opportunities. Something that's come through as a theme in various conferences, and I understand today is working with industry. We really would like to work with you, not just take your money, but work with you. We also have patients, you know, at the heart of our business, and we'd really like to work more with the NHS. Obviously, within the context of why we're here today, the QIP Safe Care workstream, which I've now found out has been renamed Harm-Free Care. It's a thing in the NHS. Why do we have to change names? You just get used to something and you think you know what the programme is, and then they change the name. But clearly, within the QIP agenda, and particularly the harm-free care workstream now, there is an objective to reduce hospital-acquired pressure ulcers. A huge amount of money is spent, up to £2 billion a year is spent on pressure ulcer management. And somebody I was talking to recently was saying that just their grade 3 pressure ulcers are costing them up to £600,000 a year to manage, and then grade 4 on top of that, almost another £700,000. So it's serious money for a trust here. So clearly, apart from all the impacts on patients, on carers, on staff, there's a huge amount of money being spent in this area as well. So, as I say, today I wanted to just talk to you about some emerging clinical evidence that we have been involved in the States. We were actually approached initially by a clinician in the States. We Monlica work worldwide. We were approached by a clinician in the States. They've had a little bit more pressure on pressure ulcers over there because of their insurance system. And a lot of the hospitals over there were told if they got hospital-acquired pressure ulcers, they were not going to be paid by the insurance companies. So that was a huge incentive, as you can imagine, for them. And this was some work that a clinician was doing over there. And one of the things, he worked in ITU, and one of the things that he was looking at was that they had very, very comprehensive skin bundles and preventative programs, but particularly in the high acuity areas. This was a high acuity trauma unit in the States. And in the ITU areas, although the general level through hospitals, through the rest of the hospital was about 1.9% pressure ulcer incidence, in ICUs and the different ICU areas, it was anywhere between 4 and 24%. And yet that was where they were getting one-to-one nursing. They actually had very comprehensive prevention programs in there with all the normal things that you do with support services, nutrition, skin care, all of those elements, but they were still getting up to 24% incidence of pressure ulcers. So he wanted to look at that, and they did quite a lot of analysis And they were saying, we know pressure causes pressure ulcers, that's why they're called pressure ulcers, but also other key factors were the shear, the friction and the microclimate, and they felt that perhaps there were some elements there that weren't really being addressed within the current bundles in that particular cohort of patients. So that was an area that he actually wanted to look at. So one of the things that he hypothesised on, that's a bit of a hard word at this end of the day, hypothesised on was what could you actually do to actually prevent some of this shear forces and some of the microclimate issues which he felt were affecting these patients. And there has been some evidence historically around using dressings, I will say the word, dressings prophylactically. And there is a lot of there's a lot of controversy about dressings prophylactically, and I think some of that is perhaps because we haven't fully understood the mechanisms of them in the past, or they have been used perhaps inappropriately, or they have been used instead of other interventions. But he was looking at this as an adjunct and saying, particularly the majority of these patients seem to have the pressure ulcers occurring in the sacral area. These 24% were in the sacral area. So he hypothesised that if you had a dressing that reduced the shear and the friction in that area, would that make a difference? And he did a study of 93 patients to look at this. And within those, he used his normal Braden score, but did some additional gradings, particularly for the ITU area, looking at those that came in and had cardiac arrest, that had surgery longer than 8 hours, that were very compromised from a hemodynamic point of view and all those sort of factors as well, and gave them extra scoring against those. And the people that came out as very high acuity were then given a sacral dressing. At this point, it wasn't a hypothesis. We weren't involved, apart from the fact that the gentleman concerned, Todd Brindle, actually came to us and asked if we would be prepared to supply the dressings. And that was the only involvement that we actually had. It's interesting. The key findings of the study at the end of the day were, of the 93 patients in the cohort that he studied, 41 of those were identified as being very, very high risk over the 3-month period. And actually, where they'd had a 24% incidence in that cohort previously, there were no incidents of pressure ulcers, which he found quite astounding. We were delighted, clearly, but it seemed a very simple adjunct intervention to actually put into place. So they then looked at that and rolled it out throughout the rest of the hospital in the high acuity areas, and actually demonstrated that they had very, very similar results in the other areas as well. Since then, he has actually done a full RCT. That's with the publishers at the moment. We're just waiting for a date. So that's showing very, very similar results. We also, a slide that's missing from my little notes here. Just an idea of the. I apologise. The picture seems to have expanded there and gone over some of the text. But as I say, these were very high acuity patients. So this was just a case study I was going to put up while I was talking, just to show you the type of patients that were involved here, and that because of all the comorbidities, you might assume would be very, very likely to suffer a pressure ulcer, and you might even say that was unavoidable in those instances. But he actually had very positive outcomes with that. Since then, there have been a number of studies done in various other areas in the States and in Europe. There are 14 studies. I'm not going to go through all 14 with you. That would just be too onerous. But there's just an example of 3 there, and all of them have actually shown where we're being very, very specific, and we're not in any way saying you put this on every patient that's at risk. Over here, we tend to use the Norton, so we're not saying anybody 10 and above do this. We're talking about a very specific cohort of patients, but we seem to be having very, very good and very, very positive results on this as well. So there's 14 other studies. To back this up, there's also been some in vitro data, just to try and understand what's actually happening here. And the in vitro data, which is sort of recreated the clinical setting as much as you can, has actually demonstrated that with the dressing that we have, it's Mepilex border sacrum, it's a 5-layer dressing, it has a silicone adhesive, we call it our SafeTac adhesive, and it's actually shown by replicating the clinical setting that it actually does redistribute the shear force by about 50%, and from Todd Brindle's and some of the other work, they're thinking that that is what is actually making the majority of the difference. It also does help with... Oh, sorry, I don't know what happened here. On my little printout, it looks lovely. Here, the graphs are popping up and down. Apologies for that. The other thing that we've actually also identified is that it actually does manage the microclimate. And if you've got some insensible fluid loss, which particularly in the sacral area, you can get pooling there. It does keep the skin dry, and there is moisture vapor transferation there that's actually managing the microclimate as well, which was another contributory factor. So what we've actually found is looking at the, we know pressure, but looking at the other areas of shear friction and microclimate, that applying a Meplex border sacrum in these particular cohort of patients does give a positive clinical effect on reducing pressure ulcer incidence in these areas. So one of the things that we're now doing is we are working with a number of trusts. We have previously worked with a lot of trusts on pressure ulcer management. We do have a lot of wound care products, so we have been working on management. We're now also working with trusts, looking at how we can support them generally with education and best practice guidelines, but also how we develop this knowledge. We're doing a lot more research as well, just to validate some of this information and how it can be embedded into skin bundles or into pathways when it's relevant, when it isn't relevant. And we'd actually like to be able to do more along those sides as well. So we do offer study days, we do education. We use a lot of KOLs. Jackie Fletcher, for instance, does some lecturing and education for us as well. We actually do have RCN accredited e-learning as well into pressure ulcers. This is not related to dressings or anything like that. This is in pressure ulcer management, including risk assessment, staging. Jackie was saying staging causes a lot of problems for some nurses. So staging, identification of pressure ulcers, things like that. Practice support tools, some of these are business-based as well. There's a roadmap there, also looking at calculations of if you're able to reduce pressure ulcers, what are the consequences of that and where could those resources be used differently. Quite important in a lot of cases for business cases within trusts where you're actually trying to justify change in the system of your processes. And we have an online community that we're just setting up as well. Website there if anybody would like to register, and that we'll then be sending out regular updates with regards to latest evidence. The NICE guidelines are being updated at the moment. They won't actually be published until December 2013, but information on those sort of things as well. We'll give links and updates on that sort of stuff as well. And finally, I did quite well, sorry, I was a little bit rushed, but I was just conscious of time there. Just some contact details there as well. If anybody would like to know a little bit more, we do have a stand out in the coffee area, if you want to go and talk to any of the girls there. Otherwise, there's our website, or also there's my contact details on there. Very happy to talk to anybody. Thank you.
Does anyone have any quick question for Helen? I know we're running a bit behind.
Everybody's desperate to get off for their coffee.
Can I just ask one question? Just how long do they leave the dressing in place? Just
on average, it's actually left on for about 3 days, but it's inspected at least daily.
Okay.
The dress, because there's not a wound there, the dressing can just be peeled back and put back on. There's no infection control risk.
Okay. Thank you.
Thank you.
Thank you very much.